Hello and welcome to Critical Care MD. My name is Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotations and you are more confident in caring for the critically ill patients. In this video, we will go over some important studies that were published within the last year and are pertinent to the practice of critical care medicine. Before going into individual studies, let me explain how I organized some important information. This format will be the same for all articles that will be discussed in this video. I will start with a screenshot of the study as shown, where you can see the title and the author list. The name of the journal and the date of publication will be at the top. The PubMed ID will be at the bottom here. If you want more information, you can enter pubmed.com on any browser and enter the PubMed ID in the search box as shown. On this page, you will find the abstract, and if you want to read the full article, link will be provided here. Keep in mind that I will only be discussing the important findings from each study, and a detailed discussion of the strengths and weaknesses of each study is way beyond the scope of this video. Let's dive in, starting with sedation and analgesia. Dexmedetomidine, or simply Dex, is a very popular sedative in the ICU. Its main advantages include minimal suppression of the respiratory drive, and it also has weak analgesic properties. Previous studies have shown that Dex is associated with reduction in delirium, duration of mechanical ventilation, and ICU length of stay. Its main disadvantage is increased risk for bradycardia, and it is also not very potent, meaning patients who are on Dex often need other agents like fentanyl or propofol, either as bolus dosing or additional infusion to control the agitation. What is not known is if Dex is superior to propofol, which is probably the most commonly used sedative in mechanically ventilated patients, as we did not really have good head-to-head comparison studies. In the last year, there were two articles that looked at this. The first one is a systematic review and meta-analysis published by the Society of Critical Care Medicine. They included 29 randomized controlled trials in the meta-analysis and found reduction in delirium and a slight reduction in ICU length of stay. They did not find any difference in duration of mechanical ventilation, mortality, or hypotension. There was increased risk for bradycardia, which is not a surprise. The next study is a randomized controlled trial that was published in JAMA. About 1400 patients were randomized to either Dex or clonidine group versus propofol. Clonidine is an oral agent with the same mechanism of action as Dex. They did not find any difference in patient-centered outcomes like time to successful extubation, length of stay, mortality, or delirium. Higher rates of agitation and bradycardia were seen in the Dex group. Agitation again is not very surprising because Dex is not a very potent sedative. In fact, in this study, they allowed the use of propofol in the Dex group for breakthrough agitation. This may have impacted the results. This was also a non-blinded study, so there is risk of bias. We still don't have a clear winner between Dex and propofol, but in general, there is evidence supporting the advantages of Dex, including reduced risk for delirium and faster time to extubation. Within the last year, the Society of Critical Care Medicine made a conditional recommendation that Dex should be considered as the first-line sedative for patients who are mechanically ventilated in the ICU. Next, we have a randomized controlled trial comparing ketamine or etomidate for induction. This was published in NEJM. About 2,400 critically ill adult patients undergoing rapid sequence intubation in the ER or ICU were randomized to ketamine or etomidate. What they found was no difference in hospital mortality, including patients with sepsis and septic shock. This is particularly mentioned because etomidate theoretically can cause suppression of adrenal axis and can be deleterious in septic patients. However, this was not proved in this study. In fact, there was a slightly higher chance of hypotension or cardiovascular collapse with ketamine. Take this with a grain of salt though, because there was a slightly higher use of vasopressors in the etomidate arm, which could have masked hypotension. Overall, this study does not prove superiority of one agent over other, and personally, I will continue to use etomidate for induction until there is more evidence. So last year, I made a similar video talking about updates from 2024, and I discussed how in the last few years there has been a major shift in the use of corticosteroids for respiratory failure. Several studies have shown improved mortality with use of steroids in pneumonia and ARDS. In fact, major societies like American Thoracic Society and Society of Critical Care Medicine have recommended that steroids should be used for these conditions. Evidence continues to accumulate in favor of steroids. This systematic review and meta-analysis was published in the Annals of Internal Medicine. They included about 3,500 patients in the meta-analysis and showed reduced mortality when steroids were used for severe pneumonia or ARDS. There was also reduced incidence of septic shock in pneumonia. They excluded COVID, influenza, and immunocompromised patients. The benefit of steroids in COVID is well established. However, there is prior weak evidence showing possibly increased risk for mortality when steroids are used in influenza. So we need to remain cautious when considering steroids in three patient populations: influenza, immunocompromised patients, and those with TB or fungal infections. Next, we have a controversial Renovate trial which compared high flow to non-invasive ventilation for respiratory failure. Almost 1,800 patients were randomized to either high flow oxygen or NIV support for respiratory failure. Five subgroups were analyzed, namely immunocompetent patients, immunocompromised, acute exacerbation of COPD, acute cardiogenic pulmonary edema, and COVID 19. The authors concluded that for the primary outcome of death at 7 days, high flow oxygen was non inferior to NIV. However, this study is far from perfect. They used an unconventional and complex approach to statistics called Bayesian model, and this study was entirely done in one country, Brazil. The sample size was also small in certain subgroups. For example, only 50 patients were immunocompromised in this sample size of almost 1,800, and more than 50% of the patients had COVID. So, despite what the authors concluded, we should continue to use NIV where appropriate, especially in patients with acute exacerbation of COPD, acute cardiogenic pulmonary edema, and immunocompromised patients until there is more evidence. Next, we have the UK ROCKS randomized trial looking at oxygen target in mechanically ventilated patients. They randomized an impressive 16,000 patients to either conservative arm, where they used the lowest FiO2 needed for a goal SpO2 of 90%, versus usual care, where the target SpO2 was left to the treating clinician. They did not find any difference in mortality or ICU or hospital length of stay at 90 days. However, despite them aiming for 90% SpO2 in the intervention arm, the median SpO2 achieved ended up being 93% versus 95% in the control arm. So the separation was not ideal here. One important takeaway for me in this study is that exposure to supplemental oxygen was about 30% lower in the conservative group. So we can at least reduce the cost significantly without harming the patient by targeting a lower SpO2 of 90% compared to higher numbers. Next, we have a systematic review and meta-analysis looking at the role of antibiotics in preventing ventilator-associated pneumonia. The reason they did this systematic review and meta-analysis is because of a prior randomized controlled trial called ProfiVAP trial, which showed an impressive 56% reduction in VAP with a single dose of prophylactic ceftriaxone in neurocritical care patients. They included over 800 patients from 7 randomized controlled trials in the meta-analysis. Only patients with acute brain injury were included. Why? Because this is the population where ProfiVAP trial showed benefit. What they showed was, in fact, prophylactic antibiotics do lead to reduction in VAP, but interestingly, there was no difference in any patient-centered outcomes like duration of mechanical ventilation, ICU length of stay, or mortality. So it's hard to know what to make of this. But as far as prevention of VAP goes, we should stick to the essential practices as recommended by Infectious Diseases Society of America. They also recommend some additional approaches, especially if VAP rates remain high despite sticking to the essential practices. This recommendation is at least a few years old and they have not yet included prophylactic antibiotics. I wouldn't be surprised if they include prophylactic antibiotics, at least in neurocritical care patients, in their next update. Next, we have a review article on tracheoinnominate arterial fistula, or simply tracheoinnominate fistula, which is a life-threatening complication that can develop in patients with tracheostomy. Collectively, they identified about 150 patients. Here are some important take-home points. The median time between tracheostomy and development of fistula was about 80 days. So this is a late complication. We are usually told that the classic presentation is sentinel bleed followed by a massive life-threatening hemorrhage. However, this kind of textbook presentation was seen in only less than half of the cases. From a diagnostic standpoint, imaging was much better than bronchoscopy, typically CT angiogram. From a management perspective, immediate inflation of the cuff and applying sternal notch pressure was successful in initial hemorrhage control in about 70% of the cases. For definitive management, endovascular or interventional radiology based approach was as good as surgical techniques. Next up, we have the STORM PE trial. In high-risk PE, which is pulmonary embolism with hemodynamic instability, the role of thrombolysis is well established. However, in intermediate risk PE, which is PE with evidence of right heart strain, the treatment is somewhat controversial. Traditionally, such patients are treated with anticoagulation like enoxaparin or apixaban. However, in the last several years, mechanical thrombectomy in addition to anticoagulation is being increasingly utilized. They randomized 100 patients with intermediate risk PE to either anticoagulation alone or anticoagulation with mechanical thrombectomy. This is the first reported randomized controlled trial comparing these interventions in intermediate risk PE. What they found was better reduction in RV-LV ratio, which is a marker of right heart strain, in the mechanical thrombectomy arm. There was also earlier normalization of vital signs like tachycardia in the mechanical thrombectomy arm. I am not yet sure what to make of these findings because, sure, there is improvement in the numbers, but what about patient-centered outcomes like mortality, symptoms, risk of recurrent PE? We still don't have that information. Luckily, this trial is ongoing and they're testing all these important outcomes, and there will be a follow-up publication which I'm eagerly looking forward to. Now let's talk about the EVERDAC trial, which was published in NEJM, looking at the role of arterial catheter in the management of patients with shock. They randomized over 1,000 patients with shock to either arterial catheter or the usual non-invasive cuff-based monitoring of blood pressure. What they found was there was no difference in mortality in up to 90 days of follow-up. There was also no difference in useful outcomes like days free from ventilator, vasopressor need, or dialysis at the end of 4 weeks. There was, as expected, increased incidence of pain, hemorrhage, and hematoma in the arterial catheter group. So what this study tells you is if you routinely put arterial catheters in every single patient with shock, you're only increasing the risk of complications without improving any patient outcomes. However, the key word is routinely. It doesn't mean that you should not place catheters when they are indicated. For example, if the blood pressures are extremely labile or if the cuff readings are deemed to be unreliable, there are still indications like this where you have to consider placing an arterial catheter. Patients in shock are commonly resuscitated to achieve and maintain a MAP of at least 60 to 65. However, there are several other subjective and objective parameters to consider. For example, lactate clearance, hourly urine output, and so on. Capillary refill time is one such parameter of tissue perfusion which has received a lot of attention following the Andromeda shock trial, which showed that Capillary refill time guided resuscitation was superior to lactate guided resuscitation and was associated with lower mortality. A subsequent meta analysis showed a poor correlation between MAP and capillary refill time. Now we have the Andromeda Shock randomized control trial, which was recently published in JAMA. They randomized about 1,500 patients to usual care or a CRT protocol where resuscitation was guided by capillary refill time and, if needed, additional parameters like pulse pressure, diastolic pressure, bedside point of care ultrasound, and so on. For the primary outcome, they came up with a composite score composed of mortality, vital organ support like mechanical ventilation, dialysis, etc., and length of stay at 28 days. The overall findings were in favor of the CRT protocol, but this improved outcome was driven mainly by the lesser need for vital organ support and not really by mortality. And like the Andromeda 1 trial, CRT based resuscitation was associated with lesser need for IV fluids. The take home point for me from this study is that we should continue to use multiple parameters when assessing the adequacy of resuscitation, and that capillary refill time should be a part of routine assessment of patients undergoing resuscitation. Major professional societies like the American Heart Association, the European Resuscitation Council, and European Society of Internal Care Medicine have updated their guidelines on ACLS and post cardiac arrest care recently. Overall, the new guidelines don't differ much from what is currently standard practice. For target SpO2, the Europeans recommend 94 to 98%, whereas AHA updated the number to 90 to 98%. This is in line with recent studies showing that targeting a low SpO2 does not lead to worse outcomes. The target PaCO2 is recommended between 35 to 45. For blood pressure, AHA recommends maintaining a MAP of at least 65, whereas European Society recommends systolic of more than 100 or a MAP of at least 60 to 65. For goal temperature, both societies endorse normothermia, so maintain 37.5 Celsius or less for at least 36 hours. For severely brain injured patients, both AHA and UpToDate.com say that lower temperatures may be reasonable. These guideline updates are huge, massive articles with more than 100 pages, but I have selected certain key points that I want to talk about. For cardioversion of atrial fibrillation and flutter, AHA recommends using higher energy, at least 200 joules for the first shock, whereas other arrhythmias like AV-NRT or monomorphic VT, you can use lower settings like 100 joules. They emphasize the importance of immediately defibrillating polymorphic VT because delays in shock are associated with worse outcomes. So, polymorphic VT needs emergent defibrillation. They also talk about the use of POCUS by experienced professionals during cardiac arrest, but as long as it can be done without interrupting the CPR. POCUS is receiving a lot of attention for cardiac arrest because you can quickly identify several reversible causes like hypovolemia, cardiac tamponade, pneumothorax, and also clues to pulmonary embolism like dilated right ventricle. Here are similar key points from European Resuscitation Council. Fine VFib can sometimes look like a flat line and mimic asystole. In the past guidelines, ERC said if in doubt, don't shock and continue the resuscitation. Whereas in the new update, they say if in doubt, immediately defibrillate. Immediate defibrillation is an important marker of improved outcomes in shockable rhythms, so I completely agree with this recommendation. For refractory VFib, which they describe as continuous VF after 3 consecutive shocks, they suggest considering changing pad position, like placing them anteroposteriorly instead. In highly monitored environments like ICU, where patients may already have an arterial catheter and end-tidal CO2 in place, they suggest targeting a diastolic pressure of at least 30 millimeters mercury and end-tidal CO2 of at least 25 millimeters mercury during CPR. Neuroprognostication after cardiac arrest is extremely challenging. Luckily, the two European societies gave some evidence-based recommendations on how to approach this. The first step really is to wait for at least 72 hours, but ideally 5 to 7 days. Next, we need to exclude all other causes of encephalopathy like sedation, neuromuscular blockade, hypothermia, hypotension, sepsis, metabolic derangements like renal failure, so on. After waiting and after excluding the confounders, if the patient is still not following commands, then we need to look for unfavorable signs. They described 6 such unfavorable signs. First is absence of pupillary and corneal reflexes after 72 hours. Second is bilaterally absent N20 somatosensory evoked potential wave in the median nerve after 24 hours. 3. Suppression or burst suppression on EEG after 24 hours. 4. Elevated neuron specific enolase at 48 or 72 hours or both. 5. Status myoclonus described as continuous and generalized myoclonus for more than 30 minutes within the first 72 hours. 6 is diffuse and extensive hypoxic ischemic injury as seen on CT scan at any time or on MRI after 2 days. If at least 2 of these 6 signs are present, then it predicts a 100% chance of poor neurologic outcome. More on that later. But if no unfavorable signs are seen, then we need to look for any favorable signs. They described 4 favorable signs. First is GCS M component of 4 or 5. So remember, GCS has 3 components: eye, verbal, and motor. On the motor scale, they can score anywhere between 1 to 6, 6 being the highest, which means they are following commands. If they have a score of 4 or 5, that still predicts better outcomes compared to lower numbers. Second is a continuous normal voltage EEG within first 72 hours. Third is lack of elevation of neuron specific enolase within the first 72 hours. Fourth is lack of pertinent pathologic changes on MRI at 2 to 7 days. If the answer to any of these 4 questions is a yes, then patients have at least 60% chance of a good neurological outcome. And higher the number, meaning if they have more than one favorable sign, the chances increase beyond 60%. If they have neither unfavorable nor favorable signs, then we still don't have a good way of prognosticating these patients. We just have to wait, keep observing, and re-evaluating. There are a couple of important things to keep in mind. Poor neurologic outcome was defined as severe disability or being dependent on others for activity of daily living. This does not necessarily mean that patient will be comatose or the so-called vegetable that laymen think about. The guideline discusses 3 observational studies where these negative prognostic signs have been validated, but the positive prognostic signs are extrapolated and not validated. Liberate-D is a randomized controlled trial that was recently published in JAMA. They looked at the impact of 2 different dialysis strategies in AKI. Over 200 patients with AKI needing dialysis were randomized to conventional arm where dialysis was done 3 times a week, or the restrictive arm where dialysis was done only if pre-specified criteria were met. For example, severe hyperkalemia, severe metabolic acidosis, anuria with volume overload. They excluded the sickest of the patients, so those needing vasopressors, severe hypoxemia, mechanical ventilation, these were excluded. What they found was a significantly higher amount of patients in the restrictive dialysis group had recovery of renal function at hospital discharge. Interestingly, hypotension associated with dialysis was also less frequent in the restrictive group, despite them having more fluid removed per session. So this study shows that by limiting dialysis in patients with AKI and only doing it when obvious signs of renal failure develop leads to faster recovery of renal function without causing harm. Next, we have the BICAR ICU trial, which was also recently published in JAMA. For context, the original BICAR ICU trial in 2018 showed that when sodium bicarbonate was used for patients with severe metabolic acidemia, it led to lower mortality and decreased need for dialysis. In the BICAR ICU 2 trial, they randomized patients with moderate to severe AKI and severe metabolic acidemia, defined as pH less than 7.2, to either sodium bicarbonate arm or the no sodium bicarbonate arm. When they used sodium bicarbonate, they targeted a goal pH of at least 7.3. Over 600 patients were included, and they found no difference in mortality at 90 days. However, the need for renal replacement therapy or dialysis was much lower in the sodium bicarbonate arm. As expected, there were fewer complications related to dialysis catheter in the sodium bicarbonate arm. Keep in mind that they used a very concentrated solution of bicarbonate for infusion, like more than 3 times concentrated compared to what you would get by mixing 3 amps of bicarb in 1 liter D5 water. So, if you want to replicate this intervention, make sure to review the study in detail and discuss with your pharmacist. We have some big news in sepsis. The updated SOFA score was just announced. The original SOFA score was published 30 years ago. It includes 6 organ systems and gives 0 to 4 points depending on the severity of dysfunction of each organ. In the last 30 years, there have been significant advances in supportive care like non invasive ventilation, high flow oxygen, mechanical circulatory support, newer forms of dialysis like continuous renal replacement therapy, and so on. So it was high time to update the SOFA score. The investigators analyzed data from more than 3.3 million patient encounters from 1,300 ICUs in 9 countries. They preserved the original 6 organ systems and the 0 to 4 scoring. However, they adjusted the thresholds. We will look at an example in the next slide and made room for new interventions. Let's compare these two tables. Here we have the old SOFA score and this one is the updated SOFA score. If you have a patient who is on mechanical circulatory support, let's say Impella, there is no mention of such treatment in the old SOFA score, whereas in the new SOFA score, these criteria are much better defined and the mechanical circulatory support is included. Also, this is more refined, like the old SOFA score simply says no hypotension, whereas the new SOFA score defines that as MAP of 70 or more without the need for vasopressor or inotropes. The SOFA 2 score has similar prognostic ability as SOFA 1. However, it does not fully replace the SOFA 1 yet because it was only based on data from ICU patients and it needs validation in other places like ED and hospital wards. Also, it was not specifically studied in sepsis, so prospective studies are needed and will be coming before SOFA 2 will completely replace SOFA 1. Tailoring antibiotic duration based on serial measurements of procalcitonin has been shown to safely reduce the duration of antibiotic exposure, but only in patients with pneumonia and lower respiratory tract infections. Procalcitonin is checked rampantly in the hospital and in ICU patients, but we don't know if such an approach can be extrapolated to patients who have infections other than pneumonia. That brings us to the ADAPT sepsis randomized control trial. Over 2,700 critically ill adult patients who were hospitalized for sepsis were randomized to antibiotic therapy based on daily procalcitonin versus standard care. They found a statistically significant reduction in the duration of antibiotic exposure in the procalcitonin arm without impact on mortality. Interestingly, they also studied CRP in this trial and found no benefit with CRP guided antibiotic therapy, or the duration of antibiotic use was same in the CRP arm compared to the standard care arm. Next, we have a randomized control trial looking at the impact of electronic alert system for sepsis. Increasingly, hospitals are using electronic medical record based screening and alert system for sepsis, but whether this leads to improved patient outcomes is not yet known. This large trial done in Saudi Arabia included more than 60,000 patients and randomized them to screening versus no screening. Electronic screening and trigger was based on QSOFA criteria for sepsis. In the screening arm, there was lower 90-day in-hospital mortality. They were more likely to have their serum lactate checked and IV fluids ordered. There was reduced need for vasopressor and lower incidence of multi-drug resistant organisms. But this was not without harm. There was increased need for dialysis and increased rate of detection of Clostridium difficile in these patients. Overall, one could argue that such automated electronic screening and alert systems lead to improved patient outcomes. And with electronic records replacing paper charts everywhere, and with evolving AI based tools, this type of automated systems are expected to play bigger role in the future. Next, we have a systematic review looking at hemoglobin thresholds for transfusion of packed red blood cells. This is a Cochrane review, which is a high standard, meticulous review of medical literature. Over 27,000 patients from 61 trials were included in this study. There are some important take home messages. We should continue to target a hemoglobin cutoff of 7 for most patients, meaning hemodynamically stable patients who don't have symptoms related to blood loss. Targeting a hemoglobin of 7 compared to higher numbers has been shown to reduce the risk of PRBC transfusion and associated transfusion reactions without increasing the risk of mortality or other bad outcomes. This is also true in patients hospitalized for GI bleeding. Sometimes patients with massive GI bleed, they need a lot of volume resuscitation with IV fluids and PRBC, but if their hemoglobin is 7 or more and they're otherwise stable, there is no need to give more blood. In fact, giving blood to achieve higher hemoglobin levels has been shown to increase mortality in these patients. There are two notable exceptions. First is acute myocardial infarction. It was found that using a restrictive cutoff for transfusion led to a higher risk of death or recurrent MI. However, the difference was not statistically significant. There is variation in practice, but until we have more evidence, it may be best to target a hemoglobin of 8 in patients with active cardiac ischemia. The other important exception is critically ill patients with brain injury, like patients with severe traumatic brain injury, intracranial bleeds, and so on. These patients were found to have improved neurological outcomes when liberal transfusion strategy or higher cutoffs were used for PRBC transfusion. It is also important to know that the TRAIN randomized trial in 2024 showed improved neurological outcomes when patients with acute brain injury were transfused for a cutoff of hemoglobin 9 compared to 7. Next up is the target protein randomized control trial. About 3,400 ICU patients in two different countries were randomized to either augmented protein supplementation or the usual protein supplementation. There was no difference in any of the measured outcomes at 90 days, including days free of hospitalization, survival, mechanical ventilation, and so on. Target protein RCT is the third randomized control trial in the last 3 years which compared high versus low protein supplementation. In 2024, the PRECISE trial showed no benefit with 2 grams per kilogram per day protein supplementation compared to 1.3. In 2023, the EFFORT trial showed no benefit with 2.2 grams per kilogram per day compared to 1.2. The American Society for Parenteral and Enteral Nutrition, or ASPEN, in 2016 recommended a range of 1.2 to 2 grams per kilogram per day for protein supplementation in ICU patients and has not updated its recommendations since. Based on these recent randomized trials, it is best to stick with the lower end of this range. Last, let's look at some guidelines from Society of Critical Care Medicine that came out in the last year before concluding this discussion. A detailed analysis of the quality of articles behind these recommendations is beyond the scope of this discussion, but I will just go over some key recommendations from them. There is increasing effort to standardize the use of point of care ultrasound in ICU and also to identify patients who actually benefit from use of POCUS. ACCM summoned a task force to go over the evidence and come up with some recommendations for evidence-based use of POCUS. They suggested that POCUS should be used in the management of septic shock, cardiogenic shock, and patients with acute dyspnea and respiratory failure. They also quoted improvement in mortality to suggest that POCUS should be used for volume management in ICU patients. They could not make a recommendation for or against the use of POCUS in cardiac arrest. They emphasized that it should not be used in isolation and it does not replace physical exam. The year before, ACCM also did a systematic review and meta-analysis on POCUS. They included 18 randomized trials and showed that there was reduced duration of vasopressor use when POCUS was used for resuscitation. There was also possible reduction in mortality and need for renal replacement therapy. I say possible because the difference did not meet the strict statistical significance. PADIS is an acronym for pain, agitation, delirium, immobility, and sleep disruption. In regards to PADIS, here are some conditional recommendations from ACCM. They now recommend that dexmedetomidine should be used over propofol for sedation in mechanically ventilated patients. We looked at some of the studies supporting this in the beginning of this video. Second, they emphasize early mobilization and enhanced rehabilitation based on improved outcomes like reduced duration of mechanical ventilation, improved quality of life, and functional outcomes. They also conditionally recommend that melatonin should be provided for all ICU patients. They could not make a recommendation for or against benzodiazepines and antipsychotic use. They also made a strong recommendation for liberal caregiver or family presence in ICU, including during rounds and bedside care of the patient. They also recommended allowing family to be present during CPR with a dedicated staff member at their side. ACCM made a conditional recommendation for employing ICU communication facilitators. This is typically an ICU nurse who provides support to the family and coordinates communication with the care teams. That concludes today's discussion. I hope you found this helpful. If you have any thoughts or questions, please drop them in the comments section and we can discuss more over there. Thank you, and I will see you in the next video.